First, I'd like to thank Professor Said for inviting me to attend this year's UEDA Diabetes Conference. It's my great honor to have this chance to discuss the issue related to biosimilar insulin. My title of my talk is Overcoming Barriers to Prescribing Biosimilar Insulin, Patient and HCP Perceptions. As you all know, even after the discovery of insulin 100 years, we're still facing the issue of accessibility and affordability of insulin. It is one of the major tasks for both WHO and International Diabetes Federation to overcome the shortage of insulin and accessibility and affordability issues in many parts of the world. After the expiration of patent of branded insulins, there is availability of biosimilar insulin as a joint effort to increase the accessibility and affordability of insulin products. Biosimilar insulin has been shown to be the safe and effective in clinical studies. A biosimilar insulin is a type of insulin that is highly similar to reference brand products. The biosimilar might be manufactured in a slightly different manner, but approval of biosimilar insulin by the FDA require that those type of insulin do not have any clinical meaningful differences in regard to safety, purity, and potency. The biosimilar insulin is the same concentration and produced using standardized manufacture and safety processes. There can not be any differences that can affect the safety. That's not tolerable. When switched to biosimilar insulin, usually the same dose will be used, but after the switching, glucose levels should be monitored closely, and then the dose of insulin will be adjusted according to the glucose levels as we practice in clinical medicine. Actually, the international organizations such as the Endocrine Society and International Diabetes Federation of Europe endorsed the use of biosimilar insulin in the clinical practice. And there's also very strict regulation measures from regulating agencies such as US FDA, EMA, and CFDA to make sure that biosimilar insulin can have the same safety as well as efficacy as original developed products. So how is the safety and efficacy of biosimilar insulin regulated and evaluated? According to European Medical Agency, World Health Organization, and FDA, a reference standard is required to assess the similarity between the reference products and the biosimilar insulin in terms of safety, purity, and potency. The comparison are made to the reference products by evaluating efficacy measures such as glucose lowering effect, change of HbA1c from one or more clinical studies. Safety outcomes, including immunogenicity, has to be determined by clinical studies. Usually, pharmacokinetics and pharmacodynamic measures should be also measured and provided the evidence. For example, there was a study comparing the PK, the pharmacokinetics among biosimilar insulins, and then the insulin aspart approved and marketed in United States and in Europe. As you can see from this a curve of pharmacokinetics of these three types of insulins, it's basically overlap. This established the PK bioequivalency between the biosimilar aspart and the aspart marketed in the United States and Europe. Similarly, the pharmacokinetics properties among the biosimilar insulin and insulin aspart marketed in the United States and Europe are also compared, and this pharmacokinetics equivalence was also established between biosimilar insulin and aspart insulin marketed in the United States and in Europe. A clinical study comparing the switching from insulin glargine to biosimilar shows that after switching from insulin glargine to biosimilar, there's no change in the risk of hypoglycemic within 12 months of observation. There are also studies showing that after switching from insulin glargine to biosimilar glargine, and after switching from insulin degludec to biosimilar glargine, the same level of HbA1c can be maintained after the switching, as well as the fasting plasma glucose levels demonstrate that after switching from brand named products such as degludec and insulin glargine to biosimilar insulins, the biosimilar insulin could maintain the same level of efficacy as well as the safety. Actually, there are also patient report outcome studies, such as this study in Japan. They use insulin treatment satisfaction questionnaire to collect the information such as inconveniency, lifestyle, hypoglycemic risk, glycemic control, and delivery system from the patients when they were switched from original insulin products to biosimilar insulin. Actually, they didn't find that patients have any issues when switching from original products to biosimilar insulin. There are also investigations among consultants, physicians, nurses, and pharmacists. You can perceive from these charts that when the consultant, nurses, and pharmacists ask how concerned are you about safety and efficacy when considering start or switching to biosimilars, the physicians and the pharmacists feel more comfortable on either starting with the biosimilar insulin or switching from original developed insulin to biosimilar insulin. The nurses are somewhat less comfort with either starting the biosimilar insulin or switching to biosimilar insulin. And this might be related to the knowledge and the familiarity of this biosimilar concept and the knowledge. Here I introduce a phenomenon called nocebo effect. This is a negative effect of medical treatment induced by the patient's or healthcare provider perception of that treatment, which is non-related to physiological action. And this is a negative mediating factors between perceptions and clinical outcomes. So the nocebo effect can lead to the following results when switching from reference products to biosimilar. It can cause no adherence, can cause discontinuation in clinical trial or registries, affecting data and results. It can also result in wasted medicine. It can also increase financial burden, increase re-switching rates, resulting additional of medications to manage side effects. It can also increase symptoms burden and psychological distress. The nocebo effect was found to be related to low quality of life, loss of trust between patients and healthcare providers, and it's also related suboptimal response or relapse of the glucose control. So how to manage the nocebo effect? It has been emphasized that comprehensive patient education and support, such as face-to-face discussion, patient information sheet, a helpline number to let patients access to the information, and regular clinical reviews and consultations can be effective means for addressing this nocebo effect. And there's recommendations from Association British Clinical Diabetologists recommendation on changing from reference product to biosimilar insulin should be considered and decided upon by the prescribing HCP and patients. It should always prescribing insulin by brand name with the device specified for that specific insulin products. A patient can expect to see similar blood glucose lowering effect and safety profiles as a reference products, and check the summary of the product characteristics to confirm stability, shelf life, and storage. To instruct the patients on the correct use of biosimilar device. To give a summary, biosimilar insulin are as safe, as effective as brand insulin, so-called reference products, and is strictly regulated. When considering switch from reference product to biosimilar insulin, consider some of the questions that patients may ask. That good communication strategies can help to prevent the nocebo effect and make the switching and treatment more successful. When describing biosimilar insulin to your colleagues, uh, provide evidence about the safety and efficacy of biosimilars. With that, I'd like to thank you for your attention. Thank you.